Hey guys, this is Casey Nelson, and I chose to do my master's research project on pediatric asthma because it is something I am highly interested in. Asthma is now one of the most common chronic diseases of childhood, so it is likely that you will encounter a patient with asthma. Asthma can persist into adulthood, but the overall management is similar to pediatrics. Pediatric asthma is a large topic, so this lecture will not be all inclusive, but the highlights, classifications, and treatments will be discussed. Asthma is a chronic disorder of airway inflammation that results from a combination of airflow obstruction, bronchial hyperreactivity, and inflammatory responses that produce a wide range of symptoms. Patients can present in various ways, but most commonly it is wheezing, which is a high-pitched musical sound typically heard during expiration, coughing, especially if it is worse at night, shortness of breath, worse usually when running around playing, and feeling of chest tightness. Common physical findings are tachypnea, tachycardia, and an audible wheeze. Other clues found in history and physical exam can assist in making the diagnosis. A personal or family history of atopy, which includes atopic dermatitis and allergic rhinitis, are strong risk factors. Allergen exposures, especially animals, dust, pollen, and secondhand smoke, are common environmental triggers. Viral respiratory infections, such as RSV and parainfluenza virus, are also a common trigger. And remember, the hallmark of an acute attack is wheezing. Pulmonary function test is an objective way to measure lung function. It is the gold standard and it is used both in the diagnosis of asthma and to follow up treatment. It should be completed before and after the patient inhales a short-acting bronchodilator. This table is mostly blank because I removed all the distractors and just left the numbers you need. So the first thing you see is that the forced expiratory volume in the first second, FEV1, is less than 80% predicted. Then you see that the FEV1 ratio to FVC, the forced vital capacity, is less than 70. Note that you looked at the actual value and not the predicted value. Next, you would give the patient a SABA and have them repeat the test. This is called the bronchodilator test. You are looking at the lung's ability to respond to the beta agonist, which is reversible obstruction. Post FEV1% change greater than 12% is a positive bronchodilator test. Decreased FEF 25 to 75 is indicative of small airway disease. A definitive asthma diagnosis can be made based on the bronchodilator reversibility test. If the FEV1 increases 12 or more from baseline, it is considered a significant reversibility, which, as we already discussed, is a sign of asthma. Asthma is classified based on symptoms the patient report and the PFTs. Ask your patient, how often are you having symptoms such as wheezing, coughing, shortness of breath, and chest tightness? How many times are you waking up at night because of your symptoms? How often are you having to use your rescue inhaler, short-acting beta agonist, to control your symptoms? Do your symptoms interfere with normal daily activities? Compare this with their PFTs and then appropriately choose the right step to start medications. An easy way I remember this classification table is that intermittent has all twos. I also don't memorize every category. If I can remember persistent moderate, then I can figure out mild and severe on either side. From their classification, choose the appropriate inhaler to start them on. First, every asthmatic patient should be prescribed a SABA, albuterol, or levoalbuterol to use on an as-needed basis for symptomatic control. The addition of an inhaled corticosteroid, ICS, daily may be added if symptoms persist. Depending on the severity of symptoms, ICS can increase from low dose to medium or high dose. Since ICS can cause oral candidiasis or thrush, dysphonia, and stunt growth in children, the addition of a long-acting beta agonist, LABA, is preferred in combination with a low-dose ICS before increasing to a higher dose of ICS alone. Examples of ICS are fluticasone, budesonide, beclomethasone, mometasone. Examples of LABA are formoterol and salmeterol. At each visit, it is important to review inhaler technique, discuss trigger avoidance, and manage other comorbidities. All pediatric patients should be prescribed a spacer to use with their inhaler. They can either use one single deep breath or 5 tidal breaths. One is not more effective than the other. Most exacerbations need a short course of oral corticosteroids. If they have allergic rhinitis or aspirin allergy, then montelukast or Singulair is a good oral medication to use in addition to their inhalers. A side effect of this medication is increased liver function tests. If their asthma is severe and poorly controlled, then asthma specialists may also prescribe a biologic such as omalizumab. And the one random fact that is an easy test question is Samter's triad, which is asthma, nasal polyps, and an aspirin or NSAID allergy. Patient education plays an important role in prevention of exacerbations. Written asthma action plan helps parents know when to give rescue medications and ED precautions that is individualized to each patient. It is important to discuss the difference between a rescue and a maintenance inhaler. A rescue inhaler is only used when the patient is coughing, and they can use that multiple times a day. A maintenance inhaler is when you use an inhaler every single day, even if the child is not coughing. Many patients get this confused, so it's important to review this at each visit. It is also important to avoid known triggers. If exercise causes the child to cough, then you can give a SAVA 15 minutes before exercise, as in exercise-induced bronchospasm. Also, if the child starts to cough when they are around cats, maybe don't get a cat as a pet. An asthma specialist once told me that the best pet an allergy child can have is a turtle. These are my references. Thank you for listening to my topic on pediatric asthma, and good luck on the pants.